Science is the great antidote to the poison of enthusiasm and superstition. Hi, I'm Juliette Sellgren, and this is my podcast, The Great Antidote, named for Adam Smith, brought to you by Liberty Fund. To learn more, visit www.adamsmithworks.org. Welcome back. This podcast has covered a lot of topics, but one that we've never explored is healthcare policy. It's a huge issue to cover, and there's just so much. It's so complicated, and I don't think anyone actually gets it. So we're going to focus on some aspects of it. We'll see. Particularly the tax exclusion for employer-sponsored health insurance, which is a mouthful. And I didn't know it existed. Most people probably don't know that it exists, but it influences almost every American, if not every American. So today, on July 1st, wow, it's July 2022, I'm excited to have the Cato Institute's Director of Health Policy Studies, Michael Cannon, to guide us. He was called the, quote, most famous libertarian healthcare scholar, end quote, by the Washington Examiner, and was the Washington Magazine's most influential people of Washington, D.C. in 2021 and 2022. Welcome.
Great to be here, Juliette.
So before we jump in, what is the most important thing that people my age or in my generation should know that we don't?
So, yeah, you gave me this question in advance. That gave me a lot of time to think about it. And it didn't just come up with one thing. I came up with three. So let me run through those really quickly. The first one is every one of your professors is wrong about something. I don't think I appreciated that as an undergraduate. When you deal with lots and lots of professors over time, you realize that they're grasping at the truth, and they have a lot of truth. They have the command of their field, and they know a lot of truths, but every one of them is wrong about something. They just don't know what something yet, what that is yet. And the only way you're going to find out is probably from talking to professors who disagree with them, and then doing your own thinking on the subject. Number two thing that I think people, your age should know, but they don't, is that you're worth more than you think. When people go into things like salary negotiations, I think this is true of men and women, although I've had a lot of women say they think women do this more. They downplay their own value, and because they're afraid of rejection. And yet I think of Charles Barkley, the former NBA basketball player, who once said, if you don't ask for what you're worth, people will think you don't think you're worth it, and then you won't get it. I've done a fair amount of hiring, and I've never been offended by someone who asked for more than I was able to pay them, or even more than I thought that they could command. So you're worth more than you think, and ask for it. And third,
those are some nice. Oh yeah.
Third, this is kind of related to that last one. When it comes to applying to schools or applying to jobs, don't take rejection personally. The reason I say that is, I used to be only on the applying for schools and job side, but I've hired a number of people over the course of my career. And I found that hiring it's hard. There's a lot of uncertainty. It really is a crapshoot. And it's really hard to know who's going to be the best candidate for a particular position. Almost always it's hard to know. And I'm always thinking, when I make the hiring decision, is this really the right person? Almost always thinking that, or is this other, person that was number two, would they have been better off? And I always worry when I'm making that decision that I'm picking the wrong one. So people who are doing the hiring decisions are probably not as sure of, or let me put it this way. When you apply for a school or a job and you don't get it, don't take it personally, because the person on the other side of that decision, the person who's making that decision, is trying to make a decision with a lot of uncertainty. It may be thinking about you. I wonder if this was the right person after all. I wonder if this is the one that got away. And so when that happens, don't take it personally. When the rejection happens, don't think of it personally. Think of yourself as the one that got away.
Awesome. Those are nice reminders, lessons, things to keep in mind. I'm glad you gave us 3. We just got some bonuses. So let's jump in. When we talk about healthcare and healthcare policy, what is it? What are we talking about?
Well, first, maybe I should validate something that you said in the introduction, which is that this stuff is complicated. I've been working in health policy now for a quarter century. And I feel reasonably comfortable in my knowledge of how it all works. But I was studying health policy. I was working in health policy for about 10 years before I felt like I had a mental model that could explain everything that I was seeing and studying. Before I could, as I sometimes say, see the matrix and understand where all the pieces go and how they fit together, and how pulling this lever over here or turning that dial over there will affect all of these other variables. There's so much going on. So I offer that to say that don't feel bad that it seems overwhelming. It is very complicated, but I do think we can simplify it in a way that is useful for most people who don't think about this stuff all the time. And one way of doing that is to ask the question, as you did, what are we talking about in healthcare care, and what should we care about, and how should we think about healthcare? Well, healthcare is there to make sick people well again, and to mend broken bones and other injuries, to lengthen and improve the quality of our lives. And in order to do that, there first has to be something called medicine. You have to have the treatments that will alleviate or cure illness, that will repair injuries. And so when you're thinking about health policy, one of the first things you want to make sure of is that you want to have in place the conditions that will allow people to come up with new medical treatments. One example is there's a disease called hepatitis C. It's a really nasty disease. It's often fatal. And a few years ago, someone came up with a drug called Sovaldi that cures hepatitis C. 97% of the time. It just cures it. Before there was no cure. It was this awful chronic illness with some treatments for it, but people would have to live with it for the rest of their lives. This is a cure. We want the conditions to be in place that will allow people to produce medicine, that will discover and develop new treatments. That's number one. Number two, we want to make sure that this stuff works. And I don't just mean that the pill does what the manufacturer says that it will do. We want to make sure that we're promoting all dimensions of healthcare quality, which is, yes, the pill works, or this doctor knows how to set a bone, or when you go into a hospital for treatment, we want to make sure that the hospital helps you rather than kills you. Because there's a lot of very dangerous things that can happen in a hospital. And those things actually do happen with some frequency. We can talk about that. So you want to make sure there is something called medicine. You want to make sure that it works. And then you want to make sure that as many people can get it as possible. Hopefully everybody. And the most important thing there is you want to make sure the conditions are right for the conditions are in place that will drive down the prices for all sorts of medical tests and treatments and so forth. Because when you have falling prices in healthcare, that's the most important thing you can do to bring healthcare within the reach of more and more people, to bring healthcare within the reach of people today who couldn't afford it yesterday. And that's true not just in the case where people are buying medical care directly, but when you have falling prices for medical care, It also means that health insurance is going to be more affordable. Health insurance is what helps you afford the things that you couldn't, the medical care you could not otherwise afford. And if the conditions are in place that will drive down healthcare prices, then that helps to make health insurance not only more affordable, but less necessary because more people can afford the medical care that they need out of pocket. So broadly speaking, those are the things that you're looking to do in healthcare, and we've just sort of almost touched on some of those conditions that you need in place in order to make those things happen. The health policies that you need in place.
I like how you called it kind of seeing the matrix. It's a good way, I think, for someone who doesn't even know anything about that sort of thing to see, oh, it takes that long. And then you reach a sort of understanding. We've seen, like, who hasn't seen The Matrix? You can kind of visualize what you probably feel when you look at all of this stuff, something that people don't really understand. It's kind of cool. But I think we should kind of go down the track of how people pay for it and health insurance and how that works, because honestly, I don't really know. I know I have insurance. I know that when I turn 26, then I will have to have my own. I don't really know why that's the case. But first, I guess, what is our current system of payments for health insurance and medicine and all of that stuff?
So maybe the first thing to understand about how we pay for healthcare in the United States is that the consumers who earn the money that pays for the healthcare and who receive that healthcare as patients, we don't really get to decide who gets the money that pays for our healthcare. In a market system, we would earn our wages, we would take money from our paychecks and we would send it to an insurance company, or we would choose who gets our healthcare dollars, which insurance company, how much insurance we buy, whether we buy insurance or just buy all our medical care out of pocket. In the United States, there's a lot of health insurance, but the consumers aren't the ones making the decisions about who gets their healthcare dollars. And we're talking about a lot of money here. We're talking about $4 trillion per year. We have a lot of insurance schemes, we might call them, that purchase health insurance for different parts of the population. The biggest part is employer-sponsored insurance. Most Americans have health insurance through an employer, where your employer offers you health insurance as part of your compensation package. They pay for part or all of the premium themselves. The employer does. They decide what kind of health insurance you get. And when you leave that job, you lose that health insurance. That's a little over 50% of the population. And because it's a working age population, they're generally under age 65, the 156 million people who are in that program. We've also got government-run healthcare programs. I should say, before we get to that, there is a small market, 20 million people or fewer, who buy insurance directly from insurance companies. Those are now, for the most part, very heavily regulated and subsidized by the government. Then we've got these large government programs that effectively provide health insurance for different segments of the population, and so purchase medical care on their behalf. There's the Medicare program, which is for the elderly, enrolls about 99-point-something% of people over the age of 65. That's a program the federal government runs, pays for it with tax dollars. There's also a program called Medicaid. People get the two of them confused a lot. And Medicaid is a program that the federal government created and provides most of the funding for, but state governments implement it. And it's a program mostly or ostensibly for low-income people who could not afford medical care on their own. And then you've got other smaller programs for different populations. You've got Veterans Health Administration for veterans. You've got the Indian Health Service for Native Americans. You also have a program for low-income children called the Children's Health Insurance Program. That is very similar to the Medicaid program. In fact, in some states, it basically is just a part of Medicaid. And I think the most important thing to understand about all of these different insurance schemes is that you don't really have a choice of whether you're going to contribute to them. Obviously, in the case of Medicare, Medicaid, these other government programs, the government is taxing you to fund them. You don't have a choice here, because if you don't pay your taxes, the government fines you and then ultimately puts you in jail if you don't pay your taxes. But even on the private side, you really don't have much of a choice, because if you don't enroll in an employer-based plan, then the government taxes you more than people who do enroll in those plans. And if you don't pay that additional tax, same thing, government fines you, ultimately sends you to jail for not doing that. So really, when it comes to the financing of healthcare in the United States, what the OECD reports is that we are among advanced nations. We have one of the highest shares of health spending that is compulsory. In other words, where the government is directing the healthcare spending in the United States. It's about 83% compulsory, and that's about the 9th highest among 30 advanced OECD nations, which sort of contradicts the conventional wisdom that the United States has a free market in healthcare.
But when we talk about universal healthcare, that term is thrown around a ton, but what does that mean compared to the system that we have currently?
Well, I think that's what I tried to describe at the beginning. You know, when you got to that third feature or aspect of healthcare where you want to make sure that everyone gets it. Universal does not necessarily mean government run. It just means everyone gets it. And a lot of people think that if the government issues a guarantee of access to healthcare to everyone, well, then that means everyone's going to get it. And they think that, not unreasonably, because in other countries, governments do issue that guarantee and lots of people get medical care. It's not quite that simple, though, for a number of reasons. One of them is that oftentimes in countries where the government issues those guarantees, people don't get the medical care that they need because certain ways of paying for medical care lead to shortages that, and what that means is you've got people waiting for medical care that they don't get. You've got people in the United Kingdom and in Canada who are waiting often for years, often in pain for say hip replacements or for cancer treatment. And there's some concern that that has actually harmed health and led to worse health outcomes in those countries. Here in the United States, you have quasi guarantees of access to care in the employment-based health system. In the Medicare program, you have an explicit guarantee of access to care that Medicare is providing universal coverage to all seniors, heavily subsidizing that coverage. But even then, you have healthcare is not universal. It's not universal because it becomes less universal because both what the government does with respect to the employer-based system and Medicare drives up healthcare prices, makes it harder for people to access care. That makes it less universal. But it also becomes less universal when these government interventions reduce the quality of care. They increase the likelihood that when someone gets admitted to a hospital, they are going to acquire an infection, an avoidable infection, and perhaps even die from that avoidable infection. So here, these efforts to make healthcare more universal can actually lead to people unnecessarily falling through the cracks of the healthcare sector by preventing the quality improvements that would make healthcare more universal by avoiding those negative outcomes, those that harmful medicine actually. So universal healthcare is a wonderful ideal. The debate over healthcare reform is what is the best way to achieve universal healthcare, universal access to quality healthcare. And a lot of people believe that is a government guarantee. But I think the evidence at this point is pretty clear that when government issues those guarantees, it makes the situation worse and makes healthcare less universal, not more.
And that issue in itself and Medicare, Medicaid, actual government directly influenced spending on healthcare and all that probably deserves its own episode where we can dive into all that sort of stuff. But what gives me hope based on everything you just said is then employee-sponsored health insurance and healthcare through your employer. Can you tell us about that and how that works, what that setup is?
Sure. So again, more than half of the U.S. population, about 156 million U.S. residents, get health insurance through an employer. It's either their own employer or their parents or the spouse's employer or a domestic partner's employer. And again, the employer chooses the coverage, takes money out of the worker's compensation to pay for that coverage. And that coverage disappears when you have a separation from that employer or where the employer chooses to drop the coverage. So I think employer-sponsored health insurance should be an option for anyone who wants to choose it. But right now, it's not just an option. It's not just one option among many that workers can choose. And that's because of something that the government does that encourages employer-sponsored insurance, or really something the government does to penalize all other forms of insurance and penalize people who don't buy insurance. Any worker who does not enroll in employer-sponsored insurance, the government effectively penalizes. And here's how. When your employer pays you $1 in cash, you have to pay taxes on it. There are income taxes, there are payroll taxes. And on average, what we call the marginal dollar or the last dollar that workers earn, on average, the federal government taxes that dollar at a rate of 33%. So when your employer pays you $1, on average, if that's the marginal dollar, then the government has taken 33 cents of that dollar. But if your employer takes that same dollar and gives it to you as health benefits, what the federal government says, and most state governments say this, is we're not going to tax that at all. When your employer gives you that dollar as health benefits, you don't get 67 cents of health benefits, you get $1 of health benefits. Now, what economists, and so this creates a big incentive for workers to enroll in employer-sponsored health insurance. And a lot of people like that idea. Economists say, well, there might be advantages, but there's also a huge disadvantage, which is you're kind of distorting the after-tax price of employer-sponsored health insurance versus not just other forms of health insurance, like you might buy directly from an insurance company, but also everything else that you might spend your money on, because that dollar of compensation goes farther when you spend it on employer-sponsored health insurance. So people end up buying more employer-sponsored health insurance than they otherwise would. And when they do that, when they have more comprehensive health insurance, that means that when they go to consume medical care, they're paying for less of it out of pocket than they otherwise would. They're paying for more of it with the insurance company's money, with other people's money than they otherwise would. And that means what? That means they're going to consume more medical care and they're going to care less about prices. I mean, if you've ever been to a cash bar versus an open bar, you know that people behave differently in these two places. They consume more at an open bar because they're not the ones bearing the cost of of that consumption. They're not the ones paying for that alcohol. Same sort of thing happens with employer-sponsored health insurance, which ends up being more comprehensive and encouraging more consumption of medical care at higher prices because the patient doesn't care as much about price as they otherwise would. And that in turn ends up driving up. First of all, that makes healthcare less universal. If prices are going up, then fewer people are going to be able to afford the medical care that they need. It also drives up the prices or premiums for health insurance, because if people have more comprehensive insurance and then use more medical care, that means more claims filed against the insurance company. The insurance company has to raise premiums to cover that. And you sort of begun this cycle by favoring employer-sponsored health insurance. You've begun this cycle that makes healthcare less universal by driving up the prices for medical care itself, as well as for health insurance. And there's all sorts of other things that happen as a result of that tax preference for employer-sponsored insurance. It has effects on workers' control over their healthcare decisions and on the quality of health insurance that they receive. So
you recently did a study about that, exactly how that works, called, let me pull up the name, and the tax exclusion for employer-sponsored health insurance returned $1 trillion to the workers who earned it. So what is this $1 trillion? How are we returning it to the workers? You mentioned that it drives the prices up. Can you work us through that logic and the study's findings?
Sure. So I think this is the most important and most underappreciated aspect of maybe the entire healthcare debate in the United States, but certainly discussions about employer-sponsored insurance. What I just said to you about the tax differential between cash wages and employer-sponsored health insurance, that's what most economists talk about when they talk about employer-sponsored health insurance and this tax exclusion that creates the tax differential. That means that the government excludes the money your employer spends on health benefits from your income and payroll tax basis, so it's not tax. That's all that means. Mm-hmm. And but I think the most underappreciated aspect of this is that the money that the employer spends on your health benefits, that $1 I told you they could give you as cash or as health benefits, that $1 is the worker's money. The worker earned it. It's part of her compensation. But whenever people talk about, and it's not just $1, across all workers, the money that employers spend on health benefits across all workers is about $1 trillion per year. That's about a quarter of the $4 trillion that we spend on healthcare every year in the United States. So that's might not sound like a lot, but $1 trillion here, $1 trillion there. Pretty soon you're talking about real money. And whenever people in health policy talk about employer-sponsored insurance, first of all, they almost never talk about how much employers spend on health insurance. They only talk about the portion of the premium that the employee pays directly, and whether that's going up or down. So they almost never talk about the $1 trillion that employers spend, and they definitely never mention that money is not the employer's money. It's not a gift from the employer. It is the worker's earnings that the employer gets to control. And why does the employer get to control that $1 trillion of their workers' earnings? Because under the tax code, as a result of this tax exclusion that we've been talking about, if employers gave that money to workers as cash, they would have to pay taxes on it, about $350 billion in taxes, just if they wanted to control that money that drives so many of their health decisions. So while most people talk about the tax exclusion as if it were a tax break, because after all, the government isn't taxing something. What's actually happening is this tax exclusion is denying workers control of $1 trillion of their earnings and a lot of their healthcare decisions, because it is penalizing them if they wanted to control that $1 trillion themselves and choose their own health insurance. The government is literally penalizing health insurance choice and forcing 156 million Americans to settle for whatever health insurance their employer offers them, which is problematic in itself. But in addition to that, there's all those effects that it has on driving up prices and making healthcare less universal that way. And the government is forcing people into a kind of health insurance that is not very secure, that is tied to a job and that therefore disappears when your job disappears. And economic research has shown that if you're a person in poor health and you have insurance that you bought directly from an insurance company, you are less likely to lose your insurance and end up uninsured than if you got it through an employer. You're more likely to lose your insurance and end up uninsured if you get health insurance through an employer. So the most underappreciated part of this of this tax exclusion for employer-sponsored health insurance is that it operates more like a tax than a tax break, because it denies workers control over $1 trillion of their earnings and their health insurance decisions, and penalizes them if they try to reclaim those things.
There's a lot to unpack there, but let's take the most recent thing you said. What sorts of penalties exist for workers that don't want to follow that path or try to spend that money differently? Do they even have access to that money?
They do, and the penalties, it's one of the things that makes this issue so complicated is that we don't call those penalties penalties. I'm usually careful to call them implicit penalties, but what they are is just your regular income and payroll tax liabilities. Again, if the employer offers you if your employer offers you $1 in health benefits, no taxes on that. But if you say to your employer, no, I want that $1 as cash compensation, and the employer says, okay, then you end up paying 33 cents in tax on that. That's a combination of your income tax liability and your payroll tax liability. And we don't call that a penalty, but that's exactly how it operates. It's a penalty that the tax code imposes on anyone who wants to control that money themselves and make their own health insurance decisions. And it's a sizable amount of money that we're talking about here. It's economy-wide, it's $1 trillion, but for a person with family coverage, we're really talking about $16,000 that the worker that employers are spending on average on coverage for workers with families. And if that worker wants to take that $16,000 as cash, then they have to pay about 33% in tax on that. They lose about more than $5,000 of that income to taxes. So you can see why people would want to stay in an employer-based plan. They'd rather get $5,000 worth of value or something close to $5,000 worth of value than lose that $5,000 to the tax man. But the fact remains that the government is penalizing them unless they give up that control of that money to their employer and give up control of their health insurance decision to that employer. And as for your question about can workers really take control of that dollar or that $16,000, yeah, they can. If they go to work for an employer that does not offer health benefits, those employers pay more in cash wages. And if you think about it, it makes sense that they would, because they would have to do that to attract workers who would otherwise go to employers that would give them health benefits. If you're not going to offer health benefits, you got to offer something that will make you a more attractive or an equally attractive place to work. And the way those employers do that is by offering higher cash wages. So in that sense, you can try to reclaim that $16,000. But if you do, you're only going to get about $10,000 or $11,000 of it because you're going to lose $5,000 or so to taxes.
And so you mentioned that it drives up prices, which makes sense because if you're going yourself, you're kind of cutting out a middleman. You're more exposed to the pricing. And so the value is more evident. That to me just is econ. But why would I pick to work somewhere where I get paid more, but I don't have healthcare as a benefit instead of somewhere with healthcare? What is the difference in quality on a practical level? What does it mean for me as an employee?
Well, the difference in quality, in what respect? The quality of what?
What am I getting out of my healthcare? Is it better to pick one over the other, and why, kind of? So
some of the reasons why people will choose to work for an employer that does not offer health benefits, they include, one, maybe your spouse is offering, spouse is working for an employer that offers health benefits, so you don't need them. You would rather have the higher wages. Two, you might be eligible for a government program that offers you health insurance, so you don't need it through your employer. Three, you might be in such good health that you don't think you need health insurance. A lot of people have very low health risk. And while it's a gamble to go without health insurance, for most of them, the gamble is going to pay off. And so they would prefer the cash to the health insurance. And finally, you've got people who are people buy insurance if they're risk averse, but a lot of people are not risk averse. A lot of people are risk seeking. They like jumping out of airplanes and riding motorcycles and taking drugs and these sorts of things. And those folks might be fine assuming the risk of going without health insurance, and they might want the extra cash so they can buy motorcycles and so forth. And keep in mind that the higher the tax exclusion for employer-sponsored insurance, or the higher the government drives the prices for healthcare and health insurance, the more money people will have to give up in order to enroll in employer-sponsored health insurance, and then the more money, the greater the cash wage differential will be between employers that do and don't offer it, and so the more attractive those jobs that don't offer health insurance will look to the people in those categories I mentioned.
This strikes me as something, the fact that it's tied to an employer, to me seems not great. And maybe that's because I grew up in an age where the generation above me are millennials, and they're kind of seem to be known for jumping around jobs. I freelance here, I do this, I do that, instead of having a lifelong job where you're with the same employer your entire life. What happens to those people? It just seems not secure in a way.
Well, never mind millennials. I mean, I don't mean that millennials, you're beautiful people. But let's look at Gen X for a moment. Gen X, they're middle-aged now. And a lot of them are in their early 50s. The Bureau of Labor Statistics reports that people who are, that the average American worker will change jobs a dozen times by the time they turn age 52.
Wow.
It used to be that when you go to work someplace, you stay there for a very long time. My father worked for IBM for 30 years, from when he was age 18 to when he was 48. And even for a little bit after that. And that's not really the norm anymore. Whereas tying insurance to employment might have seemed to make sense back then when people remained in the same job for decades, it does not make sense right now. Because if you get sick and have to change jobs or you get so sick you can't work anymore, even if you have another source of health insurance lined up, just the transition from one health insurance plan to another can disrupt your access to care. And for that reason, it makes a lot more sense. And for that reason and other reasons, it makes a lot more sense to have an ongoing relationship with one insurer and only to make changes when it makes sense for your health and your access to care. And we don't do that in the United States. Really, it's sort of because of an historical accident. We have this tax preference for employer-sponsored health insurance, not because anyone in Congress thought, hey, you know what would be a really good idea if we encourage employer-sponsored health insurance by penalizing workers if they unless they enroll in one of those plans. That conversation never happened, or at least not until the exclusion was already in place. The exclusion happened because in 1913, Congress created an income tax, and they said nothing about employee health benefits. But the bureaucrats who had to implement it said, wow, this is really complicated. Again, it's not just you, Juliette. Treasury Department bureaucrats back in the 19-teens and 20s, back when healthcare was much simpler, said that the question of taxing employee health benefits under the new income tax was so complicated, they punted. They said, we're just not going to tax health benefits at all. And that's how we ended up with this thing we call the exclusion, or this tax preference for employer-sponsored insurance. It was an accident, and it has caused tremendous damage. It has ruined people's lives by driving up health insurance and healthcare prices, by stripping people of their coverage, by leaving them with low-quality coverage on other dimensions. And Congress has had to intervene over and over again in the health sector to try to fix all the problems that this historical accident of the tax exclusion created.
I have two more questions before we go to the last question, which is the third last question, which is a little bit over time, but I think this is important. So if that works for you, can I keep going? Awesome. I'll start with a little anecdote. So I have pretty severe allergies. I went on steroids for my allergies last season, last spring. And when I went to go to CVS to pick up my prescription, I was like, oh, premiums, you pay them. They're usually not super expensive. This premium was hundreds of dollars. And so my health insurance is the one that my mom has through her work. And it seems that when I get medication for certain things, like skincare, things like that, the premium is way cheaper. And that premium for my allergy medicine was ridiculous. But that's not even the actual cost of the medication. That's not the price that companies are paying, or insurance companies pay for that. But why exactly do I don't even know how to say this question, so maybe you could help me. Why is it that my allergies are so bad and the health insurance I truly need is something that would cover my allergies instead of necessarily skincare or something like that? Is that related to this issue at all? The fact that my mom is paying her employer, we have kind of less of a say in what we're getting. I don't know how to phrase that.
No, the question you're asking is coherent and makes sense. And the answer is yes. That is a good illustration of the dynamics that we have been describing. First, I would say, I think that when you say premiums, you mean copays.
Yes, that is what I mean.
Yeah, premiums are what you pay for insurance. Copays are what the portion of the price of an individual medical good or service that you pay when your insurance is paying for the rest of it. And one question that may have been formulating in your mind is, if markets are supposed to drive down healthcare prices, if competition is supposed to do that, why isn't that happening for my allergy medication? I mean, this copay is outrageous. And
it wasn't even the full price. It was just what I was paying.
Right. It was only a portion of it. So a couple of things about that. The most important thing to understand is that is a manifestation of what I was talking about before, where if people are heavily insured, they don't care much about price. And so producers will jack up their prices knowing that they can get away with it. Insurance companies are not very good at negotiating prices, not as good as consumers are. And so the insurance company, and so producers will jack up their prices. And the insurance company, what they are better at controlling is how much your copay is. So they may be trying to steer you away from an expensive drug by leaving you with a hefty copay. But what you're not getting is, and maybe you will go to that and that less expensive drug. Maybe it's a generic, maybe it's a competing antihistamine or steroid or whatever you're using.
I was already taking the generic drug. That was the generic drug.
Right. Okay. So yeah, outrageous copays for generic drugs happen too. And the primary reason for that is that when you look at who is purchasing the medical goods and services in the United States, 90 cents out of every dollar is coming from someone other than the patient. The patient, on average, is paying only it's paying only 10 cents on the dollar for the medical care that she's receiving. So the patient, and that, of course, that's an average, and so it varies, but the patient doesn't care about price nearly as much as she would if she were paying 20%, 30, 50% on average for medical care. And that is why the drug companies and other producers are able to charge the often outrageous, often, I think, unethically high prices that they do charge. And part of what's happening is they don't just want to charge your insurance company the highest price they can. They want to charge every insurance company the highest price that insurance company is willing to pay. And so often what they'll do is they will set a list price that is so high, they don't expect any insurance company to pay that. And then they'll negotiate discounts for each insurance company based on that insurance company's market clout or market power. But then when consumers go to purchase these items by themselves without insurance, they end up paying those outrageous list prices. And that doesn't just happen with drugs. It also happens, especially with hospitals. That's where that's a huge problem. But drugs are an interesting example because there have been a number of studies that have found that the prices that the drug manufacturers charge insurance companies are often so high, and these are prices the insurance companies agree to, that if you go someplace else and pay for like Walmart and find the medication you need and pay cash, the price is often so much lower in the cash market that it could be lower than your copay. So that gives you an idea of how outrageously high the prices can get when insurance is paying if the cash price is less, not just lower than the insurance price, the total insurance price, but lower than the copay that the insurance company is making you pay. That means that insurance companies are not very good price negotiators.
And so the reason why the cash market is usually less expensive is because then it's more of a direct line to the product supplier demander type thing.
Think about that 90-10 split that I mentioned, where on average, the consumer is paying 10 cents for each dollar of medical care she receives, while someone else is paying 90 cents. Let's say it's your employer's health plan. Let's say it's the government. If I'm only paying 10% of the price for a drug, I could shop around for a lower price, but I'm only going to see 10% of the savings, and 90% of the savings from that lower price are going to go to the government rather than me. So, some people might shop around, but a lot of people are going to say, why bother? But if I'm paying 100% of the cost myself, then I'm going to get to keep 100% of the savings if I shop around. And you get a lot more shopping behavior and a lot more scrutiny of prices and even price competition when that happens. And there have been multiple studies that show this. There were some insurance companies, employer health plans, that were unable to negotiate down prices for things like hip replacements, knee replacements, shoulder arthroscopy, lead tests, CT scans, MRIs, because the producers that were providing these had so much market power, they could charge high prices. And if the insurance companies tried to exclude those providers from their insurance plan networks, their enrollees would rebel. They'd get very angry and complain to their employers. And why not? It seems like their employers' money rather than theirs, that they don't see any of the savings from those strategies themselves, at least not in a salient way. So the insurers were frustrated. What do? We can't get these prices down. The hip and knee replacements the prices range from $12,000 to $60,000, and those higher prices have nothing to do with higher quality. They're just gouging us. What do we do? Well, what they did was they did an experiment, and they said, we're going to tell patients who need hip or knee replacements that, hey, you know what? You can go to any hospital you want, and we'll pay $30,000 for your hip and knee replacement. But if you go any place that costs more than $30,000, you are paying the balance. If someplace charges you $60,000, you're paying that second $30,000 yourself. That made consumers cost conscious at the margin. It made them care about 100% of every additional dollar that the hospitals were charging them above $30,000. And you know what happened? Because they cared about the price, they began demanding price information, which hospitals often don't give out. And hospitals began giving them that price information. They did some comparison shopping across hospitals, and they changed their behavior. About a sixth of those patients switched from high-price hospitals to low-price hospitals, and that was enough to make the high-price hospitals reduce their prices by 37% over 2 years. That's about a 16. When do you ever hear about prices falling that fast anywhere, let alone in healthcare? And it is an example of, first, how much the employer-sponsored health insurance system, the government, with its tax exclusion for employer-sponsored health insurance, has driven up healthcare prices. So the first thing it does is it illustrates that. It also illustrates how cost-conscious consumers can drive down prices and make healthcare more universal by making it, by bringing it within the reach of more and more people every day.
So let's go on to reforms. I mean, we've seen that this seemingly small, seemingly maybe beneficial thing, the fact that it's tax excluded, we would think, okay, well, maybe it's not so big of a deal, but it has enormous consequences or results, if you want to call them that. What do we do? Can we get rid of it? If not, are there any reforms or solutions that will alleviate these problems?
Most important thing we can do to bring healthcare within the reach of more people in the United States, to make healthcare more universal, is to take the $1 trillion of workers' earnings that employers are spending on employee health benefits and return that $1 trillion to the workers who earned it. It's part of their earnings, it's their money. We should let them control it. And when they do control it, we should give them, free them to spend that money how they want on the health plans that they want and the providers that they want. And when we do that, they will drive down prices in the health sector and demand higher quality insurance and medical care at the same time. And these are the most important things that we can do to make healthcare more universal. Every penny you can drive down healthcare prices makes it easier for people at the margins to afford healthcare and health insurance. And it makes it easier for the rest of us to help those who still cannot help themselves. And there are a number of ways that we could return that $1 trillion to the workers who earned it. All of them. Some are more complicated than others, some more politically feasible than others, but all of them, because they would return that $1 trillion to workers, would constitute the largest effective tax cut in memory, larger than the Reagan tax cuts of 1981, which are the largest tax cuts that most people alive have ever seen. And it could do so without blowing a hole in the federal deficit. It would just give workers control over money that the tax code is now letting their employers control.
That sounds sensible. I mean, to say the least. I wish we had more time, but at the same time, thank you so much for giving all this time, because we've gone over, but I think it's super important. But one question to close, what is one thing you believed at one time in your life that you later changed your position on, and why?
Again, I came up with more than just one. I could say religion. That is certainly one. I grew up Catholic. I'm now an agnostic, but more relevant to a public policy focused podcast, I have changed my views on politics and policy many, many times since I first started paying attention to politics in high school. In high school, I was a social democrat who hung door knockers around. These are little flyers you put on doorknobs around my neighborhood for Michael Dukakis, the Democrat who was running for president in 1988. Not long after that, I realized I was not a social democrat, but I thought I was a conservative. And then years after that, I realized, no, I'm not a conservative. I'm a libertarian. And that progression was actually a very slow series of me changing my mind on individual issue after individual issue, like how best to help the poor, and my views on gay rights, and my views on the right to keep and bear arms, and all the way, within the past 10 years or so since I started doing health policy, I changed my views on certain elements of health policy, such as medical malpractice liability. So there's actually been an awful lot of them.
Once again, I'd like to thank my guest for their time and insight, and I'd like to thank you for listening to the Great Antidote podcast. The Great Antidote is sound engineered by Rich Goyette. If you have any questions, any guests or topic recommendations, please feel free to reach out to me at thegreatantidote@gmail.com. Thank you.